This week on the BackTable podcast.
So a great way to control doctors and a great way to control women is to keep them afraid, right? So you tell them that these things cause cancer. You don't explain things to them. And then we've kept them afraid. And then many people have suffered. And so that's what we need to know is the number one, does the WHI data apply to modern medical practice? And it applies for multiple reasons. Number one, it's not the common medications we even use anymore. And number two, this was in older women because that's your other risk, right? Because they were like, oh, there's risk of stroke, there's risk of dementia. No, not really. There is actually no increased risk of death by dementia. It's processed through the liver, right? So that can increase your clotting factors, increasing blood clots, and we don't even use that anymore.
Hello and welcome once again to BackTable Urology Podcast, your educational source for all things urology and then some. I'm your host today, Dr. Suzette Sutherland, and I'm super excited to have our guest today, which is Dr. Kelly Casperson, who's very familiar with BackTable Urology. We've had her on as a guest before. Hello, Kelly, and thanks for being with us today.
Thanks for having me.
Dr. Casperson is a urologist by training in Bellingham, Washington, which is way northern Washington up by the Canadian border there. She has practiced general urology, but also specializing in female urology, pelvic health. But she really has now left a general practice and started her own practice called the Casperson Clinic, which really focuses on sexual medicine and hormones. She is well known to the urologists around this area and nationally and even internationally because she has started a podcast and from that developed a book called You Are Not Broken, Stop Shooting All Over Your Sex Life, which has really had wide distribution and people have benefited from this very widely. She did a TED Talk on a similar topic. She's part of a PBS series called The M Factor, which stands for menopause, and then has now started finished her second book, which will be out later this fall, called The Menopause Moment, Mindset, Hormones, and Science for Optimal Longevity. So she's really carved out a niche for herself, not only with women's health, pelvic health, but even this area of menopause and sexual health. So we're really excited to have her today. We're going to talk today about some of the menopause issues and specifically some of the historical aspects that have gotten to where we are today. So thanks again, Dr. Casperson, for agreeing to be on our podcast here.
Thanks for having me.
With BackTable Urology, we're doing a bit of a menopause series, truth be told. We're going to be in other episodes talking about genital syndrome of menopause, GSM is what we call it, and some of the new guidelines for how to treat women with this that are sanctioned by the AUA and SUFU. We're going to talk about this black box warning on vaginal estrogen, should it be there, why it shouldn't, and many other aspects of menopause. But today, we really want to focus on the systemic effects of menopause and the role of hormone replacement therapy, or what we commonly call HRT, for treating women for all of these symptoms. And we want to look and see what are the real risks and benefits of using HRT, utilizing data that we know today. We're really interested today in dispelling a lot of the myths about the harms of hormone replacement therapy, right? So it's been deemed harmful and almost evil. Many women are not utilizing them to help ameliorate their symptoms of menopause because they're afraid, this fear factor that it's going to cause breast cancer. This all stemmed from what we call the Women's Health Initiative, which was a large population-based study which started in the 1990s, which is already 30 years ago, right? Which looked at this broad population of postmenopausal women, supplementing them with estrogen and progesterone, and those who didn't have a uterus, just estrogen, and looking to see, so what is the real risk of subsequent breast cancer? What's the risk to cardiovascular health? What's the risk to osteoporosis? So on and so forth. So they ended this study early because they saw an increase in breast cancer in one of the arms. So they stopped one of the arms of the study, and it just hit the media like crazy. with the idea that there was a 26% increased risk in breast cancer if you used estrogen and progesterone. Dr. Casperson, can you shed some light on this? I mean, that sounds horrific. Clearly, any woman who says, here's this message, I have a 26% increased risk in breast cancer if I use these hormones to help for my hot flashes, I wouldn't use it. But what's wrong with that, right? What was the methodology that happened here?
Absolute risk versus relative risk, right? And the average human doesn't know what that means. The average human doesn't know what, compound interest is, and they don't understand what 40% chance of rain means. The average person doesn't understand statistics, let alone more advanced stuff like absolute risk and relative risk. So if the incidence of something is 1 out of 1,000 and some intervention makes the incidence 2 out of 1,000, you've doubled your risk. Huge increase, right? But you're like, it's still only 2 out of 1,000. And so the most important thing to know with the WHI, I'd say 2 things. Number 1, they use synthetic hormones. So when you said estrogen and progesterone, that's actually not true. It was synthetic estrogen and conjugated equine estrogen and synthetic progestin, right? So they used medications that we don't even use right now on average. So number 1, do the medications even apply? No, we don't use those medications anymore. And number 2, were the medications actually that bad? Because we're like, oh, those were the bad ones because they were synthetic. The risk of breast cancer in the combined arm, meaning synthetic progestin with conjugated equine estrogen, was not statistically significant. You do not have to take my word for this. This JAMA article is free, full access online right now. So all of the fear of hormones, the 2 decades of doctors not being trained, the 2 decades of women not being treated, relies on a paper where it was not statistically significant that there was increased risk of breast cancer. That paper is free online. Feel free to read it now. Like, that's what's so amazingly crazy about this whole story.
Let's look at the numbers if we can. We have a very educated audience here. They're urologists, urogynecologists, APPs. So they have some, idea. Many do know statistics, but maybe not details. And the numbers here, the risk of breast cancer in the general population is thought to be about 2.33% risk. And a 26% increase in that means it went up to 2.94%, which is a 0.6% increased risk.
Yes, which was not statistically significant.
Yeah, to your point.
So it's about 4 out of 1,000 women, and then it was 5 out of 1,000 women. That's your increased risk. Same risk as statins. Nobody's losing their shit about statins. Pardon my French. But it's considered, that level of risk is considered very low risk, to the point that that's what the risk of are on other medications, but we don't lose our mind over them. So a great way to control doctors and a great way to control women is to keep them afraid, right? So you tell them that these things cause cancer, you don't explain things to them, and then we've kept them afraid. And then many, many, many people have suffered. And so that's what we need to know is the number 1, does the WHI data apply to modern medical practice? And it applies for multiple reasons. Number 1, it's not the common medications we even use anymore. And number 2, this was in older women, because that's your other risk, right? Because they were like, oh, there's risk of stroke, there's risk of dementia. No, not really. There was actually no increased risk of death by dementia in the older women. And that was in oral conjugated equine estrogen that is processed through the liver, right? So that can increase your clotting factors, increasing blood clots, and we don't even use that anymore. So there's multiple parts of the study that are not applicable to 2025 and your symptomatic 51-year-old woman, but they're coming to the doctor, describing symptoms and being told they can't be on these things because they're unsafe or they might cause dementia or breast cancer, and it simply is not significant.
You said something that bears repeating, that, many of the women that were on the study were older women. And I think the average age was like about 65, 63, 65, with most of the women actually in their 70s. So they're already 15 years or so, 20 years postmenopausal and being placed on this study and being placed on oral estrogen, which we know has a thrombogenic effect, right? Anybody who does any work, even in young girls who, want some birth control and want to be on an oral birth control pill, we talk to them about the thrombogenic effect. Are you also a smoker? Because that also increases your thrombogenic effect, so on and so forth. So
yeah, and I want to just be clear for people. When you say estrogen, the experts are going to be very picky. When you say estrogen, we usually mean estradiol, not conjugated equine estrogen, right? So conjugated equine estrogen, higher clot risk than even oral estradiol, which is still not as used as much as the transdermals that don't increase your clot risk at all. So we get very picky, just like, you're not going to say an alpha blocker or the name of a PDE5 inhibitor because they all have their different characteristics, right? And so when we talk about hormones, I prefer to really be clean on it because they do all have different mechanisms of action, different risks. And when we throw the word estrogen at hormones, everybody thinks it means everything's equal, everything has equal risks, and it's simply, pharmacology is way more complicated than that. But let's look at why the WHI studied older women. Studied older women because the primary outcome was heart disease or cardiac events, right? You're going to have to study that way longer when you start with women who are age 50. You're going to be a lot closer to your cardiac events when they're 63, when they're 70, right? And you start them on the event. So again, those women were not your symptomatic 50-year-olds who have pretty good and low risk cardiac issues, right? So number one, that's why, is they just needed to see enough events. So they had to pick older people. Number two, they picked people who were pretty asymptomatic. Why? Because if you're having raging hot flashes and I put you on a placebo and your hot flashes don't get better, you're pretty convinced you're on the placebo, right? And you're allowed to stop at any time and you can swap out, right? So, and if you, conversely, if you're super symptomatic and I give you estradiol or conjugated estrogens and you're sleeping better, your hot flashes are better, your moods are better, you're pretty convinced you're on the active ingredient, right? So they needed people to be blinded. And in order to be blinded, you had to basically be asymptomatic because hormones work so darn well in controlling symptoms of menopause. So what they did with that conclusion, though, is they said hormones don't improve quality of life with menopause. And it's like, yeah, if you picked the asymptomatic people to begin with, there's no quality of life benefit to gain. But you're not allowed then to make the statement, this doesn't improve quality of life. You picked the asymptomatic people to study.
So I wanted to go back really quickly, though, to the breast cancer scare, right? That's really where the scare came from, but also this idea that maybe it increase some or could increase some cardiovascular events because of thrombogenic effects. But there was a reevaluation after the WHI study results first came out in 2002. There was a reevaluation that came out in 2003 that said, wait. Here's some of the flaws of the study. Let's look at this a little more closely. But by then, the horse was already out of the barn. Media had already taken off. Can you talk about that? What happened? I mean, that my understanding is that with a study like this, when they stopped the arm, they just right away had a press conference, right? They felt that the news was so newsworthy, they needed to get it out there that, oh my God, increased risk of breast cancer, everybody stop.
So the press conference happened before the paper was published. And this was in 2002. There was no online access to journal articles, right? So doctors literally saw the press conference and then had to wait a week to get the article to come in the mail. Right. So there was like no immediate correction that was going to happen because you couldn't even read the article until a week after the publication came out. The publication meaning the media. And the other, you can't make this stuff, it's too crazy. The estrogen alone arm, and what I mean is oral conjugated equine estrogen, alone arm, had a 20% decreased risk of breast cancer. That never made the news. In addition, if you were on these hormones, and then you got diagnosed with breast cancer, because breast cancer is common, you had a 40% decreased risk of death. There's something protective about it. And there's multiple theories. Are you just getting a better type of breast cancer than the really aggressive stuff that's more common in people who don't have hormones? Theories about that. But if you had the bad fortune of coming down with breast cancer while you were on hormones, you have a 40% decreased risk of death. That didn't make the news. So it's this crazy, absolute opposite world of women are so afraid that any hormones, again, that's why we're so picky about when people say hormones, but any hormones cause breast cancer, and it's actually the opposite.
Yeah, I'm glad you made that distinction to make it clear, and it's really important to make that distinction that the hormones that were used then are not the hormones we even use today. So, it's not apples and apples by any means. So thanks for making that point. And then other things that actually came out from when they looked at it, the data with a finer tooth comb, they saw a 24% decrease in fractures because of the improvement in bone health.
Yeah, and that was in all women, not just women previously diagnosed with osteoporosis. So, bones have a slow, gentle decline, right? Like they're getting weaker before you would get diagnosed with osteoporosis. So even the, air quotes, healthy bones, right? You have a decreased risk of fracture when you have good hormones. And to back it up, there might be a urologist out there, I doubt it, but to back it up, like these are communicators. They work everywhere in our body. They're not just to get pregnant or to make sperm, right? Hormones work everywhere in our body, whether that's testosterone, estrogen, or progesterone. And that's muscles, that's bone, that's brain, that's heart, that's blood vessels, right? So just to back it up for people to be like, that's how this works. This is a full body system. And again, for people to, back it up, I do not want to assume that all urologists know what menopause is, because I didn't come out of residency fully trained in this. And menopause the term menopause is describing 1 year with no natural periods, because the term menopause was coined hundreds of years ago, right? So what about the people with hysterectomies, uterine ablations, IUDs, right? So for a third of women, it's a crappy definition because they don't have any periods to begin with. But no periods is a symptom of the issue. It's not the issue. Right. And so people don't understand that. And, I see this a lot in my busy urology practice is if I'm going to introduce vaginal estrogen for genital urinary syndrome of menopause, and it's 8 years since they had a period, and I'm like, well, this is because of low hormones from menopause. They have no idea how no periods and a hot flash is related to their recurrent UTIs, pain with sex, overactive bladder, and getting up at night to pee. Right. And so you have to, because society doesn't know the profound hypogonadism that is what's actually happening. And the basics is mammalian ovaries are as big as the mammal is, right? Our ovaries are smaller than elephants. Elephants have bigger ovaries. And the amount of follicles in that ovary, you burn through them with time, right? And we're simply outliving the amount of ovary that we have in our body. So we live past that. Now we live 40 years past that. And we've never aged as a society on a mass scale. So now the Gen X, the millennials, they're looking at their frail, aging, broken-hipped, dementia parents, and they're saying, is there something we can do to make frailty not inevitable? And that's where the hormone conversation really is coming in. Number one, treat the symptomatic people. But number two, there is something that happens to you 40 years without hormones. But in order to decrease the risk of those things, you can't start these things when you're 82. It's best to start them when you're 50.
With the WHI study then, and so much media that happened immediately before people got a really good chance to dive into the data. It was on the Today Show, Ann Curry did an episode and so on and so forth. It just went like a blitz, right? And so all of these people heard this, but not only women who were on hormones and fearful and thinking, oh my gosh, I have to stop, but the providers who were prescribing it then also became fearful and thought,
but not all providers.
Not all providers. No,
not all
Kelly
providers.
Casperson that had been around back then.
Well, but that's what's super interesting, right? So 10 years ago, so WHI 20 years ago, 10 years ago, there were more women on hormones in this country than now. It's actually getting worse with time. Why is that? One theory is the physicians who were like, this doesn't make sense. And furthermore, I read the paper and this really doesn't make sense, right? They kept prescribing. Now they're retired. Now they're not in the system anymore. And we got 2 decades of medical schools that didn't teach new people. So it's crazy data. In the 90s, about 40% of women were on hormones. About 10 years ago, about 10% of women were on hormones. Now, 5% of women are on hormones. And that's young. So that's like 50s to 60s. The older women it's even lower. But it's getting worse because we lost the ones who kept prescribing because they knew it was good. They're like, we're not seeing these things happen to our patients. And furthermore, the study's crap. They kept going, but now they're retired.
So now I think the statistic is that, about 5% only of internal medicine providers and GYNs actually practice in menopause medicine. And most physicians or in medical schools or in residency, they get, maybe an hour or less of any kind of menopause education, how to prescribe and how to take care of menopause symptoms. So that's the education people are getting. There's just not enough education that's being allotted to this. So that is a big issue that needs to change.
This is 50% of humans. There's no one specialty that can take care of them. To put 50% of humans into one specialty and call it OB-GYN to deal with all things. And again, menopause is cardiovascular, neurologic, GI, pelvic. Like, it affects everything. And to put that on just the OB-GYNs is incredible bias. Number two, the math doesn't math. There's about 48,000 OB-GYNs practicing in the United States of America. We have 80 million women over the age of 40. So they can't, they're busy doing other things, right? There's not enough of them. So this really is the number one reason that a woman in her 50s goes to the cardiologist is heart palpitations. She gets a Holter monitor, she gets an EKG, she gets an echo, she gets a $1 million workup, she gets told that she's fine. And she's like, okay, well, all my tests are normal, but I'm not fine, right? And it's untreated menopause. Cardiologists don't know that. So I was at this business conference in Seattle, and they were saying how women are bigger consumers of healthcare. Like, that's a bad thing because we're using too much compared to the men. And I'm like, if a woman didn't have to go to 5 different doctors before she got her menopause treated, which is the data, 5 if she's lucky. The UK has some data that they're going 8 times before they get this treated. If she got the right diagnosis the first time, maybe she wouldn't be consuming so much healthcare.
Do you think it's really not getting the right diagnosis? I mean, clearly she's not getting diagnosed, but it's also still a bit of fear on the part of the practitioner. And this isn't my bailiwick. I don't know enough about this. I've heard something about the WHI studies, but I don't know enough to feel comfortable to be able to do this type of work. Is that fair? They're worried about the medical legal aspects of it, right?
Well, yeah, but pick a medication that's safer than hormones.
Exactly.
Like, there isn't one. Taking a shower might be safer than hormones, but there isn't a medication that's safer than hormones. Like, it's literally just replacing what your body has. Like, it's silly simple. But yeah, it's not enough to just teach how to do it. You have to understand why we got so fearful in the first place. You have to dispel the myth of that. Like, there's a decent amount of steps before people are like, okay. And what I'm doing and other, advocates, physicians like me are doing is we're educating the people. Because if, number one, you're a woman, you should know what the hell's going on with your body, right? That seems pretty simple. And we know body literacy is horrible and worldwide. But it's a slow-moving ship to educate all physicians. But, we have emergency room doctors giving out vaginal estrogen now when women come into the emergency room with urinary tract infections. They're educated on GSM. It's freaking awesome. But the more women that are coming in, and again, this is 50% of the population. This is not niche medicine. This is absolutely huge. The downside is people are like, oh, so I just need to find a urologist? And I'm like, no. Like, many urologists are comfortable with this because we already do it with the men. We already do it with transgender, right? So it's actually very, very normal for us. We're the original quality of life doctors. We care greatly about sexual health. 90% of men are heterosexual. Who the hell's helping their partner, right? If anybody's giving testosterone or Viagra, you better be asking, what's your plan with the super dick, right? It's like, you got to care about the partner if you care about somebody's sex life. And so it's just a very natural expansion to say, well, yeah, hormones for all genders, sexual health for all genders. We're already doing it.
But even to go back to that, people who aren't really completely well versed in all of the details of this, and then they see things like even the U.S. Preventive Services Task Force still has recommendations that say that long-term hormone replacement therapy has no net benefit, right? But the harms may outweigh the benefit.
Why do they say that? Because they are using the WHI data. Because it is the largest randomized controlled trial that doesn't apply to the healthy 50-year-old woman. And so when people ask me, like, what do you do about prevention? I'm like, listen, number one, we have estradiol FDA approved for the prevention of osteoporosis. We've got an FDA prevention already out there. Use it if you want to use it for prevention. Like, there's not many medications that are for prevention. We've got that already. It's estradiol. Number two, it's a very tall bar to tell a nation to take a medication. We don't do it with statins. We don't do it with baby aspirin. We don't do it with anything, right? So if we're going to hold our breath waiting for the government to tell us to go on something, we just lived through COVID. We know how that went, right? Like, don't hold your breath that you're going to have the permission from, the nation to take this for prevention. But the more that you are educated and you actually understand, this is what's happening to my nerves. This is what is happening to my tau proteins in my brain. This is what's happening to my blood vessels. This is what's happening to my dendritic connections in my brain. This is what's happening to my clitoral blood flow, right? Whatever you want to bring it on. Like, when you actually understand the physiology and the biology of this, why wouldn't you replace the hormones? And, if we had a medication that you could take between age 50 and 60 and it made you live 3 years longer, most people would take it. It's called estrogen. And the WHI actually showed that. Average age was 63, but in the younger women who were in the trial, and this is on the synthetic orals, those risky, bad medications we don't use anymore, average decreased mortality to extend lifespan by about 3 years. And there's other studies also supporting that. This wasn't the only study. But when our government preventative services task force uses shitty data to enter into their statement to say this is why we shouldn't use it as prevention, we're like, we don't use those medications anymore. They were started in older women. Decent amount were overweight smokers, and already had pre-existing comorbidities. This does not apply to the healthy 50-year-old who's saying, should I take this so that I don't break my freaking hip when I'm 84?
And therein lies the problem, right? Using bad data, using the wrong kind of data, and just perpetuating it year after year, decade after decade, and still going back and saying, well, it's the largest population-based study we have, so we got to use it, right?
Well, and I think, our generation of med school, this is not, people who were in med school in the 50s, it got beat into us that randomized control trials were God, right? That's the best. And you're like, yeah, but it's only as good as does it apply to the patient in front of you. And were the results actually statistically significant, right? And we are failing the application of the WHI on both counts. And you see that also with the boxed warning. They took, that's what I harped on earlier, is you got to be specific when you say what medication you're using, because they all are different. The FDA doesn't know that. They took oral ethinyl estradiol and applied it to every estrogen product, including vaginal estrogen. And the boxed warning says stroke, heart attack, blood clot, probable dementia. It's all breast cancer. It's all wrong, right? So the truth in advertising to like the government label. And here's the exciting thing. The FDA had on a cardiac warning for testosterone. The pharma companies stepped up, said, we'll do that 5-year study. We'll sponsor a randomized control trial. And last month, they took the box warning cardiovascular risk off of testosterone.
For men.
For men. Well, there is no FDA-approved testosterone product.
No, I know. But my point there again is, there's an issue. It deals with men, sexual health, so on and so forth. And
it's a huge bias. Huge bias. And so when people say, oh, but the FDA, and it's like, do you know how gender biased this government entity is? There's been 2 testosterone products that have gone up to the FDA, and the FDA says, nope, we want more 5-year safety studies.
Testosterone for
females.
Right.
For testosterone.
Just making that point. Yep. Testosterone for women.
For women, they said, nope, we want another 5-year randomized control trial. It's $1 billion to do a 5-year study. Male testosterone was approved with 6 months of data.
Yeah. So, the goalpost moved suddenly because the gender changed. And it's like, well, what was good enough for the men isn't good enough for the women, because they're worried, again, always about hormones. And again, to put everything in one bucket, right? Hormones and breast cancer. Right? So he said it's not long enough. You need to get out to at least 5 years or 5 more years.
You want to talk about crazy stuff. Testosterone is shown to be breast protective. Number 2, estrogen is, the oral, synthetic, WHI, breast protective, 20% decreased risk of breast cancer. If there was a brand name medication that decreased your risk of breast cancer by 20% and increased your lifespan by 3 years, it would have every single Super Bowl ad.
Let's talk about that for a second. We know now that there are some positive effects. That's what you've been talking about using hormones postmenopausally, decreased colon cancer, osteoporosis, fracture risk decreases, blood sugar control is improved, cancer-specific deaths has been shown also to decrease, so on and so forth. All kinds of benefits here, let alone just the vasomotor symptoms associated with menopause and sexual health. But what are the negative effects of not using hormones?
Yeah, I love how you bring that up because I think truly, we harp on informed consent. And we always say, well, there's a risk of not doing a surgery, right? There's a risk of not taking a medication. And that is, you don't see that explained very much to people. So risks of not being on hormones. And again, hormones decrease the risk of disease. They don't make you not get older, right? Like stuff happens to us anyways because we keep going around the sun. But 1 in 2 women will have a fracture in their lifetime. If you have a hip fracture, you have a 30% risk of death within the year. There are more hip fracture admissions to hospitals in this country every year than heart attack and stroke combined. So 30% risk of death within 1 year of a hip fracture. Most breast cancer, because breast cancer, again, we're afraid of the wrong thing, meaning statistically afraid of the wrong. Let's still be afraid of breast cancer, but statistically, it's not going to kill you. So number 1 killer of women who have survived breast cancer, heart disease. It's the same as prostate cancer, right? And look where we've come, to go off on a tangent of look how fast we moved on prostate cancer. Testosterone caused prostate cancer. Stop your testosterone if you have prostate cancer. You can never be on it again. That's how I trained.
Right.
What
it's
are we
not
now?
So anymore.
Now we're like quality of life. We've done the studies. Testosterone doesn't make prostate cancer grow or cause. And we have men now on active surveillance for prostate cancer on testosterone. Like that is the absolute pendulum swing. So we can challenge dogma. We can ask questions. We can do studies. We've seen it happen, especially in urology with the prostate cancer people.
But it's interesting in that example that we give men the ability to do shared decision making, but when it comes to hormones in women, we don't give them the opportunity to make that choice, right? By doing all this care. I mean, this is coming around now. I think we are reinvigorating this discussion for this very reason, right? To give women back the information they need in order to make the decisions for themselves.
Yeah, well, and I mean, that's the crazy thing. And not until I really got on Instagram did I start hearing from so many women. We all think we're doing a good job. I think I'm doing a good job. You're doing a good job. We're all doing a good job. But then you realize the crap doctors say to women, which is wrong, ill-informed, mean, has nothing to do with body autonomy or patient choice, right? Like it is abysmal. But we all think we're doing a good job. So it's like this cognitive dissonance is a trip.
So I think, again, back to that, what's the downside then of using hormones? Like
you have to save longer for your retirement because you're going to be around more.
Yeah, right. That's a huge downside. But really, when you look at it from a medical standpoint and longevity, it'd be interesting if someone is able to do the study to look at what's the calculated increase in morbidity, some of the things you just described, which could be measured as disability, right? And mortality as measured by lives lost due to not taking the hormones.
Yep, they did that study and they basically said if we didn't, because 40% of women were on hormones in the 90s, right? So they calculated, okay, this is how many women got off their hormones and this is how much disease has gone up. And we've to say it, like it sounds so dramatic to say it, but it's like the papers show we've killed several hundreds of thousands of women by not letting them be on hormones. Because actually breast cancer is up, heart disease is up, hip fractures are up, right? Like we didn't do better when we took 40% of women off, we took 40% of women were on hormones. We took 80% of them off hormones.
Right. Well, you already said less than 5% of the postmenopausal population is on hormones today. That's the current statistic. So that's just really amazing, right?
I mean, what's so crazy, again, and this ties in a little bit to testosterone in women, but it's like we have this data in men. Like we know that men with low hormones have increased risk of dementia, depression, heart disease, diabetes, and a higher risk of mortality. We have that data in men. And we have that data in women. But there's no man who has low testosterone and we're like, well, I'm sorry, you just outlived your testicles. Like, we treat them.
Yeah. And for us, somehow, this culture seems to be more accepting of women suffering than men suffering, for sure. That's part of our, really in the world of medicine, it's still a patriarchal society. We see this over and over again. If men, when they went through menopause, right, when their testosterone levels start decreasing and their penis shriveled, right, there'd be a problem. They'd be raising the roof and industry would come up with a solution how to fix all that, right? But women are screaming and nothing's happening, right? For how many years? And just, oh, well, it's just a hot flash. It's just a little night sweat. You're just a little moody. It'll be okay, right? But we know now more. I want to get into this a little bit about some of the other negative effects, systemic effects of, the lack of hormones and the hormone receptors that are in the brain. Talk about that and where that leaves us and things that we attributed to crazy menopause and why that might be.
Yeah. So hormones help modulate neurotransmitters. So serotonin and dopamine. And so incredibly important in the brain. We know that women with low hormones, or again, you can look at it the other way, women treated with hormones, however you want to say it, have decreased risk of all neurologic diseases. Hormones protect the myelin. Hormones support the microglia. Hormones help mitochondria work. Hormones in the brain actually help the dendritic connections. I was a neuroscience undergrad at the University of Minnesota. I remember drawing the dendrites of the neurons, right? So how many dendritic connections your brain cells have helps you not have dementia, right? And those dendritic trees will actually atrophy when you don't have hormones. So more and more data, and this is a fabulous myth that just got busted, is that people said, well, the body adapts, the body adjusts. You stop having hot flashes. The body's adapting to this, right? And so Dr. Lisa Mosconi at Cornell in New York City actually has radio tracer to the estrogen receptor in the brain to prove that the estrogen receptors are going to downregulate because the body's adapting to less estrogen, right? That's what you would find if that was true. What she finds in the perimenopause and menopause time is the estrogen receptors actually upregulate. The brain is starving for estrogen. They upregulate to try to get any damn estrogen there is. And so it just turned that myth of like, oh, the body's fine with no estrogen. It's like, no. The body's scrounging at perimenopause and menopause by upregulating the estrogen receptors. Fascinating data coming out both in testosterone and estrogen looking at prevention of dementia. They just did a paper published at the UK Biobank, which is great data looking at all the Brits. Basically, both men and women in the highest quartile of this is free testosterone measured had decreased risk of dementia. So we have stronger data for testosterone in men. It's not because it doesn't exist in women. It's we don't have any money studying it. But I truly believe testosterone, again, for anybody in the back corner who doesn't understand, testosterone is made in the ovaries and you have to make testosterone to have it convert to estrogen. So testosterone's in all bodies. I didn't learn that in residency either. I don't want to assume that all urologists know that. Ovaries make testosterone, but incredibly important in the brain. I think it's a missing piece for dementia. And again, Dr. Mosconi did a meta-analysis 2023. And this is going a little bit into the healthy cell hypothesis on if you want to prevent dementia and heart disease, you actually have to start hormones in healthy bodies because hormones don't fix diseased cells. They only work by preventing. So as best we can tell, and again, we don't have a randomized controlled, placebo-controlled trial looking at dementia and hormones. It's not going to happen. But when you get a dementia diagnosis, the disease has been happening for 20 years, which means you need at least a 20-year. It's like prostate cancer and the radical prostatectomy versus radiation. It's like nobody's ever going to do that randomized control trial because it's like takes 20 years, right? So from the best we can tell from the meta-analyses, if you are on hormones young, which is between 50 and 60, within 10 years of menopause, you probably decrease your dementia risk by 30%.
Wow.
If there was a drug that decreased dementia by 30%, it would have a Super Bowl ad. And that's why like the dementia drugs don't work well, is because it's only going after the broken pieces that have been there for 20 years before you got your dementia diagnosis. So it's incurable. The meds we have are crappy and a huge problem. And why we're not talking more about the role of hormones in prevention is beyond me. There's no money to be made. These are all generics. They're not going to do a Super Bowl ad.
This idea, too, that especially in women, dementia's, higher incidence of dementia in women than men. And then we also see it present, right, in later stages, right, in later ages, in their 70s, 80s. And here you've already had 20 years of no hormones. And so that effect that you said is so important, right, in preventing.
Exactly. And again, there's many things that prove the theory, but where were you 20 years prior to 75, 55? Right? There is a direct insult that happens to the body when the body stops, basically outlives. I don't like saying ovarian failure. I like saying outliving ovaries. It just sounds a little bit more positive.
Yeah. With all the benefits then that we're talking about, the benefits, let's look at this. NAMS, the North American Menopause Society, ACOG, American College of Gynecology, the endocrine societies, they acknowledge there's some benefit of using hormones, but they still have, railings on how it should be used. And this whole idea about the timing hypothesis, how accurate it is and how frustrating this is. Why don't you speak to that?
Yeah, well, I want to clean that up because I can speak a lot about the Menopause Society specifically. And if you go to the 2022, at that time it was called the North American Menopause Society. It's now called the Menopause Society. But they put out a great position statement. It is great. It alone has been misused, right? So two important sentences from that document that, again, have been misconstrued. Number one is the benefit outweighs the risk in your average healthy postmenopausal 50-year-old. But benefit outweighs the risk. That is an incredibly strong, subtly worded, but strong statement in medicine, right? And they say that. Benefit for the average healthy, no comorbidity person, the benefit outweighs the risk.
Which means you can't say there's no risk, but the benefit outweighs the risk.
There's risk to all medications. There's just hormones have the least amount of risk of most medications. So benefit outweighs the risk. Very powerful statement. Number two, the most benefit is when it started within 10 years or age less than 60. Now, people will take that statement to say you can't start it after age 60. That's not what that statement says. The statement says best benefit is young menopause. So starting within 10 years. And that's the healthy cell hypothesis or the timing hypothesis, a couple different theories. But again, you have to put the hormones back in the healthy body. Once the body is unhealthy, hormones aren't going to help as much. But will always help the bones, right? Can always help sleep, can always help mood. And so it's like, hey, if you're 62, it's been 10 years, or otherwise a healthy person, you have many other contraindications, which contraindications are minimal. I might not prevent dementia in you, and I might not prevent heart disease happening in you, but I'm going to protect your bones. I'm going to help you sleep better, make your skin look nice, right?
But one of the messages of how that got interpreted was you should only use it for maximum of 10 years. Use it the smallest dose possible to get rid of your hot flashes and your night sweats. And for the shortest amount of time possible, we'll take you off periodically to see if you still have those symptoms. And God forbid, not longer than 10 years. I've had so many women in my practice that were successfully on systemic hormones, and then their provider took them off because they said, well, I was on it for over 10 years. And now they're coming to see me because of genital urinary issues.
Yeah.
And I'm like, well, why'd you stop your hormones? Well, my PCP said I couldn't be on it any longer, right? So that's what's happening today.
Yep. And this is what I tell people, because we've got receipts for this, right? All these myths, they're wrong. So go to the 2022 menopause guidelines, and they say as long as the benefit outweighs the risk, you can continue on your hormones. It says that. And where the littlest amount for shortest amount of time came from was after the WHI. Some people felt like they needed to do something for women and have permission to give them a little bit. And so that kind of eked out as don't worry. We'll give you a little bit and we'll stop it soon.
We'll give you a little whiff.
Right. So, but people took that as a medical guideline. It's not a medical guideline. And current statement, so people will say, how long do I have to take it? And I try to make fun of everything. And I'm like, well, do you plan on being buried or cremated? And they'll tell me what they think. And I'm like, great, take it to the urn. Take it to the grave.
There's such an emphasis in medicine about prolonging life, right? Increasing our longevity.
Is there?
Well, I think modern medicine is. It's all about trying to increase how many years we live, but we want those years that we live to be good quality lives, right? And so that's what it's really all about.
Urologists are the original quality of life doctors. I think urologists care greatly about quality of life. Otherwise, we wouldn't have 5 different ways to get your dick hard, right? Like, so we care greatly about, guys come in there like, oh, my ejaculation's a little bit less. It's a little bit too quick. It's a little bit too long. It's a little bit yellow, right? Like, we care greatly about sex life and quality of life. So, it's crazy. And again, this is our superpower being urologists taking care of women as we see how men are taken care of. And like, it's basically malpractice if you consent a dude for prostate surgery and don't talk about sexual side effects, right? Like, no urologist does that, right? And then here we are with women, and it's like, dude, you need insurance prior auth to do nerve sparing for nipple preservation for breast cancer? And we don't have to get a freaking prior auth for nerve sparing for radical prostatectomies.
Wow, I didn't know that.
The bias is huge. And so to me, I'm like, urologists get that because we take care of men and we understand that that is a human part of us, is how we feel and how we act and what our relationships are like. And you look at gynecology and you're like, dude, nobody asks a woman like, hey, should we talk about cervical sparing hysterectomy or not? Like, do your orgasms come from deep penetration and cervical stimulation? That's not how they do not have that conversation.
Yeah.
The average man doesn't know his erections come from the nerves around his prostate, but we preserve them just the same.
So luckily, right, there is a big reevaluation of all of this data. There has been over the last 5 years or so, but it really is making more of a media round. There's some stars that have gotten involved, right? They're going through menopause themselves and saying, what the hell? I don't have any options. I don't have to live like this. And a lot of effort is being made now to try and educate women, to your point, educate the public, and then also educate providers. That's really where I think a lot of the emphasis also has to go. Tell us a little bit more about this PBS series that you were involved in called The M Factor.
Yeah, so M Factor is a documentary, and it basically interviewed both women, patients, and doctors about their experience with menopausal medicine and kind of went through the WHI, the bias in healthcare, how women have always kind of been second-class citizens, and really what we have to do to change, to turn the big ship. Huge. It's been shown in 42 different countries. They're working on international rights for translations right now. A clip of it was shown at Davos, at the World Economic Forum, because there's a clip in there about how many women leave the workforce because of untreated menopause. So that's fascinating data. So it's really starting to, again, people, if you all you know about menopause is that it's a hot flash and no periods and you can't get pregnant, like, you don't understand the profound hypogonadism and the neurologic dysfunction that comes from this. And men wouldn't tolerate it. There'd be a national vaccine if your testicles fell off at age 51.
Yep. This has been wonderful. I mean, the main message is here, menopause is real, right? The symptoms that women get, they vary. It's not just the classic ones that we know of. The quality of life issues really matter, and really increasing our longevity, but doing it in a healthy way is really what's so important. And we do that in other areas of our life, right? But we've missed the boat on this part. And I'm glad that we're really trying to take another deep dive into this, the use of hormones in women, and just really, so women don't have to suffer like they have for so many years. So thank you.
Thank you for putting it on platforms like this. I mean, it really takes all physicians to be supportive and, to support their patients and to truly, again, we're nerds. We want to understand the biochemistry and the neurologic, we want to understand that. And you can't understand this subject and be profoundly moved by how poorly we've done in this massive area of medicine. So thank you for bringing it to BackTable Urology.
Well, this has been a wonderful episode. I'm really excited. And again, I think it's in September or October, your new book is coming out on menopause. So it's going to be filled with all the kinds of things that we talked about today and then some. So I'm really looking forward to getting my hands on that book as well.
Yeah, you can pre-order it now on Barnes & Noble and Amazon. It's called The Menopause Moment. And it goes into how to talk to men about it, how to talk to your doctor about it. And it talks about the 3 main hormones that we use, which is estrogen, progesterone, and testosterone has its own chapter. GSM has its own chapter. So really to help people understand what's going on, because when people have the education, they can make the right decisions for themselves.
Great parting words. Thanks once again, most sincerely, Dr. Kelly Casperson, for sharing your expertise with us. This was very entertaining and lots of fun. Thank you, Kelly.
Thank you.
I'm Suzette Sutherland, your host for BackTable Urology Podcast, signing off.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
thanks again for listening and see you next week.